Yeah.
Now we come into the second speaker for today MRCP webinar. The junior doctor called Jamal Ahmed. Jamal, thank you very much for joining us. He's one of our bright junior doctors. Graduated from Manchester in 2017. He got his MRCP 3 years later in 20. He's ex-deputy representative of Wales for the Sudanese Junior Doctor Association. He's ex-RCP associate college tutor between 2020 2022. And beside, he's now being a gastroenterology specialist trainee on the West Deanery. Jamal, thank you very much for being with us today. Please take the platform for you, put your presentation. Thank you very much.
Thank you very much, Prof, and thank you to Professor for this invitation. I will be speaking for 20 minutes today on the MRCP Part 2 written exam, and I will touch upon a gastroenterology interview course that I run for higher specialty trainees. So the aims of my talk this morning really is to provide, to help the candidates really better prepare themselves for the MRCP written Part 2 exam. I will also provide an introduction to key resources that I feel was beneficial for myself when taking the exam. And I will aim to provide an ideal revision strategy for the candidates as well. I will briefly as well touch upon a SWOT analysis as well, and I'll briefly introduce you to my interview course that we've been running for the last couple of years. So moving swiftly on, what exactly does MRCP Part 2 entail and what does it focus on? Well, there's a range of different core components to it. Firstly, the aim of the MRCP Part 2 is to help you prioritize diagnostic and diagnostical problem lists. It focuses on investigation planning, and there is a wide range of questions that test your ability to select plans for immediate and life-threatening conditions, as well as long-term and chronic management cases. There is also a focus on the assessment of prognosis in patients, and there is also a quite considerable amount of input from national and clinical guidelines which you need to be aware of in order to succeed this exam. Now, as I'm sure most of you are aware, to sit the MRCP Part 2, one of the eligibility criteria is that you must have passed Part 1. So in terms of a move away from the clinical sciences that are focused in Part 1, what are the additional components of the MRCP Part 2? Well, it is more clinically orientated, which means there is a focus more away from the clinical sciences and basic sciences. There is a focus specifically on clinical photographs in the exam, which come within a booklet. And these range from a variety of different specialties, such as dermatological cases, which are actually very, very easy marks should one be able to sort of master them. There is also a range of pathology slides that are tested upon, inheritance trees, but more importantly, there is quite a firm focus on radiological imaging, such as chest X-rays, CT scans, and MRI images. Now, I will touch upon later on some resources that I would advise candidates to focus on to master these sections. Furthermore, there are ECGs as well as echocardiograms which come up in questions. And for some of the listeners today, it may be worth noting down a key resource, which is a book authored by Dr. John Hampton, which is titled 150 Cases of ECGs by John Hampton. This is a very relevant resource that I found helped me through my journey. And actually, how does one become more clinically sound in sort of answering these questions, which focus on sort of the clinical photography, inheritance trees, imaging, and stuff like that? Well, I feel that attendance at MDTs as part of your clinical work are important. Attendance in outpatient clinics where you see, can discuss, chronic cases as well as imaging can help. And attendance through ward rounds in your clinical work alongside your seniors, such as your consultants. Now, in terms of preparation for MRCP Part 2, well, from my opinion, I think this exam warrants at least 3 to 6 months of preparation and input. Now, the amount of preparation needed is obviously dependent on various external factors. various people may have family commitments, personal commitments, busy work schedules. So it's very important that you factor this into how many months you need to put in for your MRC Part 2 revision. But I think as a ballpark figure, 3 to 6 months is just about right. Now, I would advise junior doctors who are embarking on the MRC Part 2 to adopt a consistent approach to their work. And this would involve roughly 2 to 4 hours per day. And I think it's quite important to allocate this time, whether this is early in the morning, if you are a morning bird, or late in the evening after your day's work. I cannot emphasize the importance of having exposure to countless and plentiful amount of MCQs. And I will touch upon various question banks later on. But as a rough ballpark figure, you would be expected to have actually been introduced to almost 3,000 MCQs in order to prepare yourself adequately. And again, remember, early planning equals maximal success. So honing in and being more specific in terms of what revision materials there are available for candidates. Well, as I touched upon before, there are question banks available. The most common ones are Past Medicine and Past Test, as well as BMJ. And these all incorporate subscriptions, which you'll have to pay depending on how long you want them for. There are 3-month subscriptions, 6-month subscriptions, as well as 12-month subscriptions. From a personal point of view, I felt that Past Test was actually the superior question bank, because I felt that the question bank in the subscription was actually more realistic to the exam. There was quite exhaustive questions, and I felt that learning from the answers was most beneficial and why the other answers were wrong. And I think this is something candidates should really focus on in terms of learning and revising, trying to understand why the other answers were not right. And essentially you can hit 4 birds in one stone here using this technique. In terms of moving away from Past Tests, Past Medicine is very useful, but this is more beneficial for guidelines. So I would advise candidates to use Past Test as their primary question bank and use Past Medicine from a guideline point of view. There may be people who benefit better from books and reading. There is a book titled Essential Revision Notes for MRCP. This can be bought on the Amazon website, and you just need to go into Google and you'll be able to find this book. And again, prices are not too costly and it's all worth the investment. There may be some candidates who benefit more from listening, for example, rather than reading. And there are a variety of podcasts available on the Past Test subscription as well, which you can listen to if you're driving in your car to work, for example. You could turn this on in the car on the radio and you can listen. And I found this very beneficial, and particularly for MRCP, but also for PACES, which was talked about earlier. There is also the option of revision courses that one can attend. These range from half-day courses to 2-day courses. I don't think this is necessarily a mandatory requirement, but if you are someone that feels that you would benefit from courses, then of course this is another option for you. And finally, there are flashcards that you can use. These are basically notes that you can make yourself, and you can pin them around in your house so you have easy access to quite concise range of notes that you've made. Right, so what is my advice in terms of a revision strategy moving forward? Well, I think most of you would have passed part 1 before embarking on part 2. So I think it's important that you find out what your current level of knowledge is. Remember, part 2 is a higher yield exam. It's a more complex exam, and the pass mark is generally harder for this. And I think one question I would advise candidates to really ask themselves is, how far are you away from where you want to be before the exam? What are your strengths and what are your weaknesses that you need to focus on? And I will touch upon a strategy which I'll help you use to sort of focus on your strengths and weaknesses and use these to tackle MRCP Part 2. I would advise that you individualize your study plan. Please learn from the feedback scores you got from your Part 1 result to look at the areas where you're weak in and the areas where you need to pay more attention and focus to. As I touched upon earlier, please look at what materials work best for you and make this concise. Focus on major specialties first, because you will notice from the MRCP website that there is a larger majority of questions are entailed from the internal medical specialties, specifically cardiology, gastroenterology, respiratory. This is where you'll get your marks. So please focus on these first, but do not neglect the more smaller specialties, for example, things like infectious diseases, dermatology. So it's important to pay respect to them all, really. And I would also advise candidates to adopt an approach where you can manage your time effectively. I found from my experience in part 2, this exam is quite time consuming and you may not have time to revisit all your questions twice over. So please use mocks in the subscriptions that you buy and time yourself before the exam so that the real exam does not come as a shock to you. So I cannot emphasize the importance of good time management. Now, I will focus briefly upon an established technique used to manage one's time, and this is something called the SWOT analysis. SWOT analysis, so this is SWOT. What does this mean? So this is an acronym. So S stands for strengths. Focus on themes that you are familiar with, topics that provide a favorable environment for you to study. For example, you may have scored very highly in cardiology, for example, in your MLC Part 1. So this is an area that you may want to sort of tone down a bit and possibly focus on other areas. W, this is your weaknesses. Focus on areas that you are less confident in and areas that you need to pay more time towards. O stands for opportunities. What do I mean by this? Look at allocating specific times in the day where you work best. Some people may work well in the morning, some people may work well in the evenings. But what other opportunities do you have in MRCP Part 2? Well, you may want to seek help with a like-minded study partner. Some people are individual learners, but others can flourish and benefit from study partners. So this is an opportunity for you to find someone at work with you, a colleague maybe, sit in the exam, who is able to work with you and push you. There may be some candidates here who have young children, young families. So it may be that you need to look at hiring childcare for your children on weekends, because this may be a time where you want to study. So think about these things. Think about planning your way around this. And this leads us on to T, the last part of the acronym, which is threats. Think about things which will distract you away from the revision process and how you'll combat them. What are the threats? So threats could be things like busy work schedules. You may have a very busy IMT rotation, which involves multiple on-call shifts and nights. So think about how you will maneuver and navigate your way through this and to adopt a good revision technique. You may have family events, holidays. So please think about how you're going to navigate these threats to ensure they do not distract you from succeeding in this exam. What I'm happy to do is share an example of my SWOT analysis maybe to the organizers afterwards, to the candidates, and I can share this with you to something that I constructed for myself. So in summary, what is my advice for MRCP Part 2? Well, I can't emphasize the importance of preparing and planning early. Maximize the use of question banks. Remember, past test is high yield, and I think this should be the #1 resource for candidates. Individualize your study resources, and I've touched upon this earlier, and I've given you a number of resources that you can use. Focus on your weak points, and again, look back at your MRCP 1 feedback to areas that you struggled in, and areas that you can improve for next time. Attendance at multidisciplinary team meetings and clinics are really important. So do not miss out on this opportunity, because a lot of the skills and knowledge you learn here is transferable to the exam. And finally, please do not underestimate this exam, because once you pass it, you are 2/3 of the way through MRCP, and you can embark on PACES and successfully achieve your MRCP. What do I advise candidates briefly upon success of MRCP? I would advise you to book your PACES as soon as possible. Why? Knowledgeable is very transferable from MRCP Part 2 written to the PACES. So it's important that you Book it early whilst your knowledge is fresh and you are ready. And please keep up and refresh your knowledge after passing the exam with relevant clinical guidelines, because this will help you in day-to-day practice. Briefly, I will touch upon my gastroenterology higher specialty interview course to some of the candidates who may be interested in a career in gastroenterology. This is a course that I introduced and we started in January 2023. We have very excellent feedback from candidates, and we charge very respectable prices, which are competitive. We help candidates to tackle high yield questions when it comes to the exam, and we provide them with an opportunity for a mock interview course where we provide them one-to-one feedback. And actually, I'm proud to say we've had a number of candidates who have achieved high specialty numbers this year in gastroenterology. So thank you very much for allowing me to talk. I'm actually about to start a night shift tonight, but if there's any questions anyone has, I will provide my email address and I'm happy to answer.
Thank you, Jamal. Really much appreciate your effort. You look very bright, junior doctor. Absolutely wonderful. What you've done so far is great. All questions and answers would be at the end of the webinar. So we have already some questions written up there. What we let you know, you stay with us as far as you can, because we still have 2 more speakers. The next speaker is Tariq. Ali, Tariq, are you around? Tariq? I can see your picture there, but are you around? No? Yes, he's around.
Hi, yes.
Hello, Tariq. Yeah, let me
Hi.
introduce you to the audience. Tariq Ali is ST4 anesthetist. ST4 mean a registrar who's year 3 or year 2 registrar in the old system. He works at a very prestigious place in London called Guy's and St. Thomas's Hospital, which is a big tertiary center. And he got his MRCP physiology, and beside that, he is ALS instructor and a FICE accredited. So he's coming today here just to help you or to share with you about his own experience of dealing with the MRCP exam. Tariq, the platform for you, please.
Thank you. If you could share with me the screen so I could upload a
Well,
PowerPoint.
yes, what happened, Prof. Amr, he can make you a host.
Yes, that would be great.
Co-host now is part of.
You co-host? Are you co-host now?
Yes.
Yes, I'm just.
Yes, if you're co-host, you can share your document.
Okay. Can you see my screen?
No, no. Are you looking at the roof? Is your screen on?
I think I've got it on privacy.
No, it's fine. Take your time. There's no panic.
Okay, I'll have to quit and reopen it to do that. That's okay.
I can share your presentation. I have it open.
All right. If you hold a minute, I can make you a co-host, and you can share it from your side.
That's good. No, she's around. Yeah, good. Brilliant.
Nora, you are a co-host now. Okay.
Yeah, we can see it now, Tariq. You can kick off.
Thank you very much. So I'm Tariq, one of the anaesthetic ACCS trainees who's Southeast London ST4 trainee at Guy's and St. Thomas's. I have an interest in critical care and anaesthetics, so I've gone on to do the MRCP as it's quite useful for ICM. And I've also done the primary anaesthetic exam. So I just want to talk you through what my experience was doing the MRCP. Next slide, please, Noor. So we're just going to talk through the format of PACES, what skills are assessed, what the mark scheme looks like, and then just particular focus on the different stations. So the examination, communication, consultation stations, and then a bit about how to actually prepare for it. Next slide. So the stations have changed. So if anyone has done it in the last year or 2 years, they would have noticed that it's changed. And if there's someone that's taken a slight hiatus and taken a break from doing it, you'll experience something slightly different. So there are 5 clinical stations, each of 20 minutes. Just give me one moment, guys. I've just got a thing. 1 second. Apologies. So there's 5 clinical stations. Station 1 is a mix of communication and examination. Station 2 is a consultation of 20 minutes. It was previously a history station that's no longer included. 3 is an examination, 10 minutes in cardiovascular and 10 minutes of neurology. 4 is a mixed communication and abdominal. And 5 is another consultation. So there's a stronger focus on assessing your clinical and non-clinical skills based in both communication and consultation aspects, rather than the history base, which is far more focused at sort of foundation year level. There's a lot more focus on actually interacting with the patient and making a management plan. Next slide. So these are the 7 skills that our professor was speaking about a moment ago. And I just want to draw particular attention that you can read them all on the left side: physical examination, physical signs, clinical communication, differential diagnosis, clinical judgment, managing patient concerns, and the last one is managing patient welfare. Now, on the right side, we've got the most recent mark scheme and what their past percentages requirements are. And you can see on average, you need to be getting above 60 to 65%. You should be aiming for 70 to 80% at least. You'll notice that the last mark is for patient welfare. This is a strong emphasis on the PACES exam, is actually maintaining your safety throughout all the stations. This involves in terms of the mannerisms towards the patient, body language towards the patient, and ensuring that you don't cause them any significant harm. And this includes how you examine them as well, particularly with things like the abdominal station, where you do need to palpate. What you want to do is warn the patient, inform them, and make sure that they're not in any discomfort. So this is something that they've moved the target much higher to 87.5%, because actually you shouldn't be causing any harm to the patient. And this is something that's consistent in all stations. Okay. Next slide. So the mark scheme, I think this has already been touched on, but we'll just go through it again. 2 examiners in each station. Sometimes you may have a third person. This is sometimes an invigilator. They're assessing the setup of the exam to making sure that everything's safe and everything's fair amongst all the examiners, but not necessarily examining you. There will be essentially a total of 10 examiners across all stations and the host examiner. Each is marked based on 2, 1, and 0, based on satisfactory, borderline, or unsatisfactory. If you are borderline throughout all stations, you pretty much will not pass. You need to be scoring high enough marks in some stations to push you over that 70% boundary. At the end of at the beginning of each PACES rounds, there is a round of calibration. This is where the examiners will go around and assess the patients, making sure that they set a benchmark for what is acceptable as being a satisfactory, what is a borderline, and what's unsatisfactory. You should highlight anything that you find that feels more unsafe or more, in particular, unfair to you in that particular time. But generally speaking, they will assess this all beforehand. You must pass all 7 skill stations, all 7 skills, and the overall minimum score. You may find some candidates that will pass all 7 skills, but not the minimum score, or they will pass most of the 7 skills, pass the minimum score, and still fail. So you need to do both 7 skills and the overall minimum score. Okay, next slide. So we've covered this already, but essentially this is to highlight that it's 10 minutes, 20-minute stations, and time flies. It's 2 hours with multiple breaks in between. And you can see that they're scattered between communication and consultation. That's the main focus of the MRCP now. So we're just going to start looking at the different types of stations and some tips involved in each one. Next slide. So if we're just focusing on the examination station to start with, things that I think get you marked right at the beginning is wipe. So make sure that you wash your hands, introduce yourself, permission to examine the patient and expose adequately. You must never compromise the patient's safety. This includes things like not clamping a chest drain, not removing oxygen, not moving an acidic drain to above the patient's level. These are all things that aren't particularly safe. So you shouldn't be allowed to be put in a vulnerable situation like that, but you definitely shouldn't put that on the patient, okay? The things that I would say are most important are inspection from the end of the bed. 70% of your marks are going to come from information you can gather when you look at the end of the bed, okay? So this means looking at what's around the patient, including oxygen cylinders, paraphernalia, such as medication that might be on the bedside, walking aids, and then finally looking at the patient, looking at them from head to toe or whatever system that works for you, peripheral to central, head to toe. That's what I used to use, just head to toe. Make eye contact, look at their muscle, see if they're wasted, move down onto the chest, onto the abdomen, onto the legs, look what's around them. Have they got catheters? Have they got drains in? Before you move off the patient, before you move towards the patient to start examining them, you should already have an idea of what type of patient this is. For example, in the respiratory station, if you see a patient who has a midline sternotomy scar and it's a respiratory station, your mind should be thinking of only a few things. And this means that your examination should focus on those things and make it essential that the examiner sees you're looking particularly for those things. For example, have they also got a thoracotomy scar? Have they had a VATS procedure also done? Have they also had any radiofrequency scars as well? So these are things that you will want to pick up on. And you know that when you come to present this patient, you've got most of the information before you've even seen them. Okay? The patients are there to be examined. They will not slow you down. Okay? So if you ask them to lean forwards, they know that that's something that they're going to be expected to do. They will lean forward. Okay? The thing that fails people most in the examination station is not knowledge. Most people will be able to recognize what type of murmur they've just listened to. The difficulty will be getting that information in a very quick amount of time and being able to deliver that information succinctly. And you cannot do that without practice. You need to be practicing this. It's not the knowledge, it's the timing. If you run out of time, you probably won't pass because there's a lot of information to get across to the examiner. Okay, next slide. So I think I've mentioned some of these points already, but be systematic, move from peripheral to central, and make it obvious to the examiner that you're doing certain things. What you don't need to do is say what you're doing. In my opinion, and to what I've been taught, do not say out loud, I am looking at the hands, I am looking at the nails. But what I would recommend is lift the hands to make it obvious that's what you're looking at. Look at the nails. The examiner is paying attention to what you're doing. That's what they're there for. You wouldn't examine a patient in ED, for example, and talk out loud to no one. So you're not expected to do the same thing here. Pay attention and make sure that it's drawn to the examiner's attention that that's what you're doing, okay? To finish your examination, you will need to thank the patient, and then I would recommend getting used to doing an S-bar type handover to the patient, to the examiner. So what your initial presentation, what your initial differential diagnosis is, the positive findings, important negative findings, and then they might ask you about investigations and other things, including bedside investigations, other investigations such as echo CT, and then a referral. So this is the examination station. Next slide. The communication stations often made people feel very uncomfortable. It's now 10 minutes only, as opposed to the 20 minutes that it was before. And I think this makes it quite challenging. This is the ability to draw information from your patient, but also to engage in them, what their ideas, their concerns, their expectations are. And it's focused the entire 10 minutes on the patient. Previously, there was a Viva component, particularly in the last 4 or 5 minutes in a 20-minute slot, that allowed you to have an interaction with the examiner. That does not exist anymore. You need to transfer this information to the patient. So this includes things like what kind of things they can expect, whether it's referral, whether it's an investigation. Things that get you good points are having ensuring confidentiality, being empathic, and actually trying to interact and engage with them about what their biggest worry is. And generally speaking, it might be one significant worry or multiple small ones that you'll have to pick apart from. There is information on here about ethical or legal requirements. So one thing that I would particularly recommend, if you move on to the next slide. One thing that I particularly recommend is looking at the patient's social factors, the ADLs, what's important to the patient. I know from my experience that things that came up were things like driving. This was a patient who had a heart condition that wanted to know particular detail about driving. This isn't something that you can pluck out of thin air. This is a very narrow line between you saying something that's incorrect or lying, and that will be an automatic fail. You need to either read up on the DVLA or know how to access it. So refresh yourself on these small things that can creep up that make a difference between a borderline and a clear pass. You'll have a 2-minute warning bell at the end of the 8 minutes before the complete 10 minutes is over. If by this stage you haven't reached a management plan with the patient, you need to move on to that. There will be points to address the patient's concerns with your management plan, and you need to be able to get onto that to be able to get those points. The only way you're going to do this again is by practicing. So we'll come on to tips to do that at the end, but you definitely need to practice the station. It is pressed for time, as are all the other stations, but this is really, really pressed for time. So try and be calm, collected, have a structure in terms of what you're going to ask, what you're going to address, and the plan that you're going to have at the end. Okay. Next slide. So the consultation station, initially a few years ago, it was just a single station, and now there's 2 stations. This is because of the high yield of marks and the high benchmark to get in those points for what would essentially be the medical registrar. This is because it actually involves all 7 skills, and it allows you to demonstrate your skills in such a way. It's the most natural station. It's one where you need to take a focused history, a focused examination, communicate precisely, make an impression, and come up with a management plan. I say focused for all those things because if you take a 10-minute history and a 10-minute examination, you'll run out of time. This is something that's generally a little bit more straightforward. These are patients, for example, obstructive sleep apnea or diabetic neuropathy or MS in a young patient. So it allows you to take a history, have a small group of differential diagnoses, and then make a plan with that patient. Next slide. So what I would recommend doing is taking a focus history, and when you have an idea as to what this station involves, at that point, it's safe to do something. Examine the patient while taking the history. You're looking for particular points in your examination. This will make you look very slick and very rehearsed and practiced, and it will make it look like this isn't your first time doing it. So continue talking to the patient while doing examination, gather physical signs, and then say, right, I think we need to talk about a management plan. These are my thoughts. Do you have any worries? Are you concerned about anything in particular? And allow them the opportunity to ask you questions. This is a very, very difficult station because if you take too long in history and then move on to the examination, you will run out of time. PACES is purely time-based. It is knowledge, but like we've said before, you will get that from MRCP Part 1, and you will definitely get that from MRCP Part 2. PACES is about time and looking like you've done this before. So make sure you have done it before. Do lots of practice. Just move on to the next slide. Other way. Great, thank you. So you do have rest stations, and these are a very good opportunity for you to clear your mind, breathe, drink water. If you need to use the bathroom, do it at the beginning of the 5 minutes, not when you've got 1 minute left on the rest station. Don't worry about the stations you have gone through already. I'm a very, very pessimistic person when it comes to exams. I walk out of everything thinking I've failed them. And alhamdulillah, I haven't failed anything for quite some time. But we are all very critical of ourselves. And the worst time to be critical of yourself is during the exam. So do not worry about what you've experienced already. You may have passed, you may not have passed. It doesn't matter. You've lost anything that's gone past you already, you will not have the opportunity to get. But anything yet to come, you do have the opportunity to get full marks in every station afterwards. So breathe, smile, make it look like you're having a good time. you've got a day off work. Next slide. So in terms of actual preparation strategies, practice history taking, practice physical examinations, you need to be doing this regularly. And I think the best way to do this is actually get feedback from either senior peers or consultants who are examiners in PACES or have previously been examiners in PACES. They will give you really pertinent details about what you're doing wrong, what things you can change, to make yourself a standout candidate, okay? So you need to be practicing regularly. And I emphasize that it needs to be someone who can give you feedback. If you're practicing with someone else who is doing PACES, that's fine, but you will not get the same quality of feedback as you would do with a consultant who probably doesn't care too much what you think about them, as opposed to a peer who you're working alongside during the exam. So get your consultants, get your senior registrars to come and give you that help. There are resources available. We'll just go back. There are resources available, such as textbooks, online courses, mock exams, but practice is the most important thing, okay? Next slide. So things that you can do include clerking patients on AMU. This is your day-to-day job, but treat it like it's a PACES exam. So go to see each patient with, yes, this is an opportunity for me to learn something. This is an opportunity for me to really auscultate that lung and really listen for what the sound sounds like. Okay, so what does open crackle sounds like? What does a pansystolic murmur? What's a renal bruit? Look for these signs, because this is what you're going to be doing in the exam. Make sure, I think this mentioned before, go to clinics, especially if you work in a DGH that doesn't have access to certain specialities. Ask where you can visit these clinics. This is a really good opportunity for you to see MS patients, motor neuron disease patients, or patients who have suffered from chronic pain, for example. And what I would say is that a lot of people take to PACES as being an opportunity to say, I have seen so and so many patients, and I've struggled to pass PACES. It's not about how many patients you've seen, it's about how much you learn from each patient you've seen. So each time you see a patient, really focus on what you're going to be taking from this one patient. It may be a liver patient that you examine and find out that actually the way that you assess someone for splenomegaly is very poor. And that's something that you can take forward, okay? So that's actually the quality of each examination that you do, rather than the number of different diagnoses that you've seen. Join your local WhatsApp group for PACES. There is almost every sitting a WhatsApp group. Ask around, get in contact with people, and join a group and ask your consultants. Most of them are more than happy to watch you assess a patient. You just need to buy them a coffee and get them to come and see your patient, okay? And lastly, the advice from before from Dr. Jamal was to move on from MRCP to moving on to PACES. I agree with this completely. I did part 1, part 2, and PACES in the quickest amount of time possible, because it's a sieve. You will lose that knowledge, too big a time period, and it will just leave your brain. So you need to move on to PACES as quick as possible, and that doesn't give you a lot of time to practice. So use every opportunity, including your on-calls, to try and get something done. Next slide. In terms of resources, I would say that the only resource that I really used was a book called Pocketbook for PACES. I have no affiliation. I don't get anything for them, but they're an excellent resource. I carried them with me. I carried that book with me when I went into work, because it meant that I could just quickly read something that I thought was interesting at the time, or revise from that. It's a very good resource. It gives you a snapshot of each disease, each diagnosis. What are the clinical signs? What's the history like? What investigations you can expect? And beyond PACES, I think it's an excellent resource. And I think that's the only one that I really use. I used Cases for PACES as well. This is a short book and it's 3rd edition. That's very good. It's got quite a few cases from all the different specialties, and it really tells you about each different diagnosis and how to examine it. It doesn't tell you as many differentials as Pocketbook for PACES, but it tells you the ones that are very likely to come up in your real exam, and those are the ones that I would take from it as well. There is MRCP clinical cases as well. I did not use it, but I've heard very good things about it. And what I would say is that that nothing replaces clinical practice and feedback from supervisors. If you have prepared for PACEs by reading a book, you will fail. There's an absolute guarantee you will fail. You need to examine patients. You need to touch patients. You need to look for clinical signs. You need to see nail pitting and question, is that actually nail pitting? Because I've not seen it before, and ask someone to confirm it. Yes, it is. Now I know what it looks like. I will wait for it in the real exam, okay? I know a lot of people then talk about courses. I've not included any courses in here. The course that most people advertised to me was a course called Pass Paces, which is an excellent course to my knowledge, but I didn't go on it purely because it's a very expensive course. It costs quite a lot of money, and it's another time for you to examine patients. I think I was getting enough experience on my days off and after my work to try and see those patients. I don't think I could afford to spend that much money on it, but it is a very good course and it does have a very high pass rate as well. So I would recommend it to anyone who feels like courses is the way for them. Next slide. So I think I've touched on a lot of these points already, but make sure that you do what you're saying. So don't just say you would ballot the kidneys, don't say you would listen for the murmurs, actually listen to them. And you might be surprised that while listening for a murmur, if you're doing it as just routine, you might actually hear something and have to think about whether or not it's a systolic murmur or a diastolic murmur. And then you're going to feel for the pulse because then you've heard something. So get into the habit of feeling for the pulse and listening for a few beats from each one. Search for the answer, okay? They want to see the process. They want to see you look at a patient, be systematic, be structured, and get to the answer that you're getting to. So they want to see the whole process, making sure that you have a patient-centered approach. And this makes sure that this includes addressing their concerns. Give the patient in the consultation and in the communication station an opportunity to share what their main concerns are. You may be solving problems that they don't really care about. Ask them what it is that they expect from each thing. Patient safety is paramount. If you compromise patient safety, you will fail. And make sure you have developed a strategy to move on between stations, particularly when you feel like it hasn't gone very well. Okay, next slide. Last things I would say is that you should feel stress. Stress is good. It's a way of you reaching your peak of performance, but too much stress is bad. So make sure that you take lots of breaks in between, okay? Appear confident. The examiners can smell fear, I think. So be prepared to look like the medical registrar, that they feel that they can leave at hospital at night to make sure everyone is safe. You're there to make people safe. You're not there for the 1 in a million diagnosis. It's about safety. And then what we spoke about earlier involving the rest stations, the ones that I thought went worst were the ones that I scored the hardest and the best. And that's probably because the examiners want to push you until they feel like they've exhausted all that you know. So if you feel challenged, good, you're probably doing something right. Lastly, I'd say plan something nice. It's a very stressful experience doing this exam and completing the MRCP. So make sure that you've got something nice planned for the week, for the weekend, whatever it may be. Treat yourself. We work long hours, late nights, weekends, as I'm doing now, Jamal is doing, Jawad is doing. We have to look after ourselves. So plan something nice and it will help you forget the stress of PACEs. Next slide. Thank you very much for having me. If there's any questions, please jot them down in the questions and I'll try and get to them.
Thank you, Tariq. Thank you very much. Yeah, we would have a Q&A session at the end. Thank you for this lovely presentation. Very mature thoughts, very wise suggestions and advices. I'm coming now to our last speaker. He's a Prof. Amr Al-Safar. He's a well-known practitioner. He's a senior consultant in Wales. His specialty is stroke. He's very much involved in education. He's one of the executive committee members of our IMA UK. We are delighted to have him with us today to share with us his thoughts about the MRCP, and I hand over the platform to him. Please, Prof.
Thank you, Ali. Thank you very much. I just wanted, of course, I'm thanking Tariq and Jamal and our colleague Prof. Sulaiman Khatib for their presentations, and especially Jamal and Tariq, because they shared their current experience with the MRCP. I'm not going to take long time. I prepared a few slides, but few of the information has been mentioned already. And I'm going to represent here in this meeting the professional part of the examination. On behalf of the Royal College of Physicians, London, I was serving as a counselor to the Royal College of Physicians for 4 years and be part of the college business for that time. So with regard of the performance at MRCP, I would like to pay your attention to the analysis that was done to the candidate performance in the 3 components of the MRCP exam, MRCP UK exam, to establish when they are most likely to pass. Okay, so this is analysis data collected from the 2010 to 2011 MRCP UK examinations, pass rates of candidates who gained their primary medical qualifications in 2005 or later. So the results have been analyzed, and it showed from a total of 22,827 candidates were included in the study, 54.8% from part 1, 24.3% from part 2 written, and 20.9% from the PACES. And the results show that candidates are more likely to pass part 1 and part 2 written 12 to 24 months after graduation, and to pass the PACES 36 months after graduation. And that's really very important, to be quick after graduation. The information is fresh in your mind, and the enthusiasm for the examination. When we consider the training program for physicians in UK, successful candidates are likely to be in foundation programs, okay, or early core or specialty training when they achieve success in the MRCP. At the moment, some candidates are dissuaded from taking the examination during their foundation for different reasons, but the data showing that their likelihood of success is highest during this period of training, foundation training, and the early years of specialty training. The analysis also shows that for candidates who fail their first attempt, delaying their next attempt by 1 day significantly increases the likelihood of them passing at their next attempt. So that's, again, very important. And all these have been mentioned. This is obviously the MRCP UK divided into these parts, and following completion of the examination, successful candidates are invited to attend the ceremony at the RCP. I attended a few of them as part of the panel welcoming the members to the new membership, and in that lovely building in the Royal College, in the first floor of the Royal College, where the old library is. So the entry-level exam accessible to doctors with a minimum 12 months MRCP Part 1, 12 months minimum postgraduate experience in medical employment, and it covers a broad range of topics to ensure level of knowledge is appropriate to physicians at beginning of postgraduate training. And it's all about acquisition of a representative sample of medical knowledge, skills, and behavior as specified in the UK specialty training curriculum for core medical training, internal medicine training. So that's really very important to refer to is the core medical training curriculum, which we're all familiar with. So knowledge as an essential base for the practice of a clinical reasoning, and that's why it is the focus on the knowledge acquisition for these examinations, especially part 1, and building on knowledge of basic medical science gained in undergraduate education. The purpose of part 1 is to test knowledge and understanding of common and important disorders as outlined in the curriculum that I referred to. Of course, that doesn't mean that you don't update yourself with the new guidelines, UK national guidelines, as this is very much required. And one of them, a recent one from NICE and the Royal College is about TIA and stroke management, for example. In fact, Clinical Medicine Journal, which is the mouthpiece of the Royal College of Physicians, very important journal to read. Today, a new issue of this journal, there is something about the new guidelines for stroke and the discussion about this. So it's really very useful to update yourself, even at that stage of the examination, the part one. So part one is a valuable milestone during training and helps to prepare you for the challenging part two written and the clinical exam. So as I said, the clinical science forms the basis of all medical practice, and that's why it is important component of the part one examination. These are different, let us say tens of books about the examination and the medical science, basic medical science and the clinical medicine and essential revision. The books that Tariq and Jamal referred to are very important. This is their personal experience, and everybody has her own personal experience in this examination, in addition to the courses, of course. So part one, MRCP, I should say that because we are recording this meeting today, so it will be posted on a YouTube channel and will open to other colleagues from national and international colleagues, especially in Iraq. For example, as we are Iraqi Medical Association with links with Iraqi medical schools all over Iraq. So MRCP part one is 1 day exam, 2 3-hour papers, 100 multiple choice, best of 5 questions per paper, no images, and computed based, administered by a SARPAS at a test center internationally or online by a proctoring service in the UK. So it's online as well, part one, and even places. Applications made outside opening and closing dates will not be accepted, and from home or your office-based online examination is only available to UK-based candidates, international candidates in a federation training program, and trainees based in Malaysia as well, they can. So from 23-24, part of the exam and so forth, delivery of part one moved to online, center-based exam for the international candidates, and that's important. And of course, if you go to the website of the Royal College and the MRCP UK, you see how to apply stage by stage on part one online application, how to pay and declaration form. All these are really very important. So online application, and if you are unable to make this application, you can obviously contact the team, request a paper application form. And you can only apply for first time for part one exam. You are required to submit evidence of your primary medical qualification, of course. And copies of qualifications will only be accepted once a registration period is open and candidates have submitted an online application. These are very important. Part two written exam can be taken by physicians in training who have passed MRCP part one, MRCP UK part one exam. And part two builds on knowledge assessed in part one and tests the acquisition of a representative sample of medical knowledge, skills, and behavior as specified in the curriculum, as I said. So since 2018, exam now consists of 2 3-hour papers, each with 100 questions. This is part two written exam, and the exam will test your ability to apply clinical understanding, make clinical judgments and clinical responsibility for prioritizing diagnostic or problem list, planning investigation, selecting a plan for immediate management, selecting a plan for long-term management, and assessing prognosis. These are all we face it on daily basis in medicine. So this is the front page, the cover of the curriculum for internal medicine, and this was revised in 2016 as well. This specialty training curriculum is so important to read and go through it. Part two, so it's 2 papers taken on 1 day. Papers last 3 hours each, 100 multiple choice questions, best of 5 per paper. Questions include images, and computer-based, administered by Surpass at a test center internationally or online via a proctoring service in the UK. It is available as well. Delivery from now on move to online of the part 2 and center-based exam for our international candidates. So apply online through my MRCP UK account, your my MRCP, which is on the newly developed, very well presented website. Only a few days ago. It's a new website now. And the main steps are log into your My MRCP UK account. Check that all your personal details are up to date. Fill in details about whether you are training in UK or not. Choose a center where you would like to take the exam. Complete any special arrangements where applicable. And pay, of course, for the exam. Now, Baghdad and Erbil, there are 2 centers now for the examination, which is really very good news. And in addition to, of course, Jordan and Amman and other countries, Bahrain, for example, is a center as well. So in 2020, RCP, Royal College of Physicians, introduced an online version of Part 2 exam, which is taken using a proctoring service. And this is available for candidates within the UK and the Republic of Ireland. International online exam. Some spaces are available to sit online exam overseas as well. And internal medicine trainees currently enrolled in a training program accredited by the Federation of the Royal College of Physicians can apply to the online option, which relates to their program as well. For example, we are very interested in the association with this scheme of international medical training initiatives. In fact, I was talking about IMT in our last conference in September in London with the Iraqi delegation was in the room as well, listening to this presentation. So this is an international scheme organized by the Joint Academy of Medical Royal Colleges. Is not only specifically for physicians, is open to surgeons, radiologists, and anesthetists as well, who are overseas internationally graduated doctors, especially middle income and poor income countries who wanted to train and come to work in Britain for only 2 years, having their primary exam or Part 1 exam cleared and having good score in English language, 7.5 they asked for IELTS, for example, and occupational language assessment. So these 2 conditions on acceptance into the IMT, and they do for you an interview on the Skype from London office, and you are in your office, for example, in Baghdad, and then they'll accept you for 2 years paid job in the NHS while you are doing your diploma, your MRCP here. And maybe you finish the work, you're gaining the experience within the NHS and gaining the full MRCP as well. So these are very good scheme. It's paid job is very good, only for 2 years. And the Home Office, they give Tier 2 visa for the candidate of this examination on the request of the GMC and the Royal College. So it's really good. Obviously, for any online exam, you need IT setup at home, and there are a few emails, at least 3 emails from the Royal College about that to come to you personally if you apply for this. There is always help from the MRCP office, examination office at the Royal College with any questions that you would like to be answered. So RCP is pleased to confirm as well the new format, as previously referred to, PACES 23, has now been introduced from the 3rd date of 23. So now it is in use, and all information guidance on the following PACES pages refers to the new format of the exam. Now, they restricted the exam, any stages of MRCP UK exam, limited by 6 attempts, not the 7 years. Okay, so if you cleared Part 1 and comes after more than 7 years, and you want to apply and go and attempt Part 2, and after that the PACES, then that's allowable. The exam set rigorous standards to ensure your competence across a range of skills, as we know, It's designed to test the clinical knowledge and the skills of a trainee doctors who hope to enter higher specialist trainings ST3. And that's a part 2 clinical examination, the PACES. And you can apply online, as we said, and if you are unable to make an application online, contact the college, relevant college of entry, request application form. And this is the diagram, shows the timeline and the stages of the PACES application periods. So that's really very useful to go through as well. And before applying, to speed up your application, make sure you have details of your training and work history available for the last 12 months, hospital names, addresses, dates of courses, and dates of previous PACES attempts, if there was any. And check that you have the correct login details for my MRCP UK online account. That's very important. If you cannot remember your login details, then contact the College of Entry, and the College of Entry, obviously, that's London and Edinburgh and Glasgow, and of the central office to reset these for you. Eligibility, MRCP UK has removed the previous regulation, as I said, requiring candidates to pass MRCP UK Part 2 written and PACES exam within 7 years or of passing Part 1. So this has now been superseded by the new limited attempts policy. So candidates will have a maximum of 6 attempts at any part of the MRCP UK exam and will not be able to continue if they reach this level without passing it. So candidates who achieved a pass in Part 1 longer than 7 years ago can now continue to apply for Part 2 written or PACES, provided they have had fewer than 6 attempts. So that's important to highlight. And the examinations, needless to say, are mapped to the UK core medical training curriculum and internal medicine training, and knowledge of this and UK national guidelines should form part of your preparation for the examination. And of course, NICE guidelines are important. Courses are available. The Royal College, they have courses as well, a number of courses available that are designed to help you prepare for MRCP UK exam. Online, MRCP UK Diploma PACES courses and courses in RCP Edinburgh and in Glasgow as well, and online preparation for PACES 23 course, which is really very good. That's the workplace-based assessment for the period and for after 3 years after the foundation. So this is the pathway for physician training in UK, and how long it takes, then the credentials here after you finish specialty internal medicine stage 2 training, and this is 4 years after the 3 years of internal medicine stage 1, after the 2 years of foundation. So you are looking for 9 years after graduation. And then the post-CCT credentialing, and we have something called the specialty certificate examinations. Overseas doctors, they can do that before they finish their MRCP, but the UK, they need to finish and then go for the specialty certificate examination in different branches of medicine. So this is this page provide more information about each of the 11 specialties, including exam and resources, and this include acute medicine, dermatology, endocrinology, diabetes, European specialty exam in gastro and hepatology, geriatric medicine, medical oncology, European specialty exam in nephrology, neurology, palliative medicine, respiratory medicine, and rheumatology. Thank you so much for this. And if there is any question, I'm quite happy to answer.
Thank you, Prof. Very much, really, a very knowledgeable presentation and very helpful, really, from a senior point of view. Well, in fact, we were so pleased to have you all today, in spite of the few hiccups we have to start with. But now we're coming to the end of our webinar. We're coming to the question and answers. I leave you in the safe hand of Noura. She is ready for you.
Yep.
She can organize all the question and answers. Noura, take the lead, please.
There's thankfully not much in the way of questions and answers. I think our speakers have done a great job at answering everything, really, during their presentations. There was just one question for Dr. Jamal, which was, what was the name of the book again that he mentioned during his presentation? And he answered right below that. Essential Revision Notes for the MRCP, which I think was brought up a couple times afterwards anyway as well.
Yeah, it's good. I have a question. I know nothing about MRCP as an exam, but now I know a lot after I heard what I heard today. What is the prices? Talked about a very expensive course. What course are you talking about? Because people abroad probably don't know about that. So how much is that expensive course cost and all that?
Maybe Ali can answer and Jamal.
Yeah.
Jamal, the mic, your mic.
The Tariq may tell me otherwise, but I think there's an East London course for PACES. It's 3 days. I think it's approximately £2,000, that ballpark figure.
And do they accept overseas?
Just to come in on that, yeah. So it's called Pass PACES, and it quotes something like 85% of candidates pass after sitting the course. It's 3 days. They do it in different parts, but it's an East London course. It is very good. If you have not seen patients of a certain nature, they will bring them. There are patients with Marfan's, there's patients with ankylosing spondylitis, there are patients with interstitial lung disease, there are patients with SPK transplants. You name it, they pretty much will have those patients. But it is about £2,000. And I think the thing that I found difficult about that was, one, it's a lot more than the budget we had for courses. So it would come out of own pocket. And secondly, is a lot of my colleagues that did the course often
Stopped. Tariq, are you still with us? Yeah, Jamal.
Probably. Yeah, Jamal, you
Jamal,
can add up to that. Yeah.
Sorry, your voice. Sorry, 1 second.
Yeah.
Oh my God, am I echoing?
No, that's fine. Tariq, carry on.
Can you hear me?
Yes, we hear you. We hear you.
His mic is gone.
Yeah, Jamal.
For those listening, I mean, I passed my MRCP PACES without a course. I don't think it's mandatory to attend a course just to pass. But if you're the type of person who feels that they need to tick all the boxes to be sure and confident they've done everything in their capable hands, then do the course. I think you can get away without doing the course, to be honest with you. It's a lot of money. You need 3 days away, often in London. So it's all individualized. Depends what you feel is necessary for you.
Okay, for some people who are at home and in Iraq, for example, and they want to come and sit the course, do they get a visa for that, or?
I don't know, to be honest.
You don't know. You haven't met like overseas candidate coming just for the course, no?
No, I didn't attend the course, so I'm not sure.
Just on that, I think not for this exam. I've organized other courses where people have come in from abroad for the exam, but to my understanding, they are not visiting on the premises of attending that course. So they may have a visiting visa, they may have a visa for other purposes, but they aren't. Their primary reason for that visa is not the course.
And similar courses, do they have it in the Middle East, for example, in certain countries, or people who cannot come to UK, because you can sit the PACES in the Middle East, is it?
Yes. Yeah, well, that's locally, Ali. They can arrange it locally. There is a representative now in Baghdad, for example, in Baghdad Medical School for the Global Office of the Royal College of Physicians, London. And they have meetings together, and they have ability, obviously, to organize a course. No prerequisite credentials to organize the course. This depends on the facilities available locally in the hospital and the job itself and how they can organize themselves in the small examination office for the colleges in Baghdad University and between them and the Royal College of Physicians, London or in Glasgow or Edinburgh. So that's something that they need to do it locally, because there are few colleagues who are definitely capable, few fellows, and recently there were more fellows from Iraq to the Royal College of Physicians.
Really? That's very good. Yeah,
Really good
absolutely.
pair of fellows, yeah.
Absolutely. That's very good. I'm very happy for that.
Yeah.
Yeah, well, thank you, everybody, really. Thank you for being here today. Thank you for you sharing your thoughts. As a Prof. Amr said, this meeting going to be recorded. The video would be out soon on the YouTube.
Yeah.
And whatever I mentioned here is going to be for the public knowledge.
Yeah.
And thank you and have a lovely weekend, all of you.
Thank you.
Bye
Alex.
for now.
Thank you.
Bye-bye.
Bye-bye.
Right.
Thank you.
Thank you.